in children, experience and outcomes. Performance, Mama Nazarov, Uzbekistan. Please.
Can I start? Good morning, everyone. I am pediatric surgeon from National Children's Medical Center in Taşkent. Today, I want to share our experience with laparoscopic Kasai portoenterostomy for biliary atresia in children. I will talk about our technique, our result, and what we learned from this experience. Let me start with why this topic is important. Biliary atresia is rare but very serious condition. It is most common reason why children need liver transplantation. Without treatment, these children cannot survive. The Kasai portoenterostomy is still the first treatment we do. If we perform it early, ideally before 30 or 60 days of age, the child has a much better chance to keep their own liver. Next slide, background. Traditionally, the Kasai procedure is done as an open surgery. This is a standard approach in most centers around the world. But open surgery has some disadvantages. The incision is large, children have more pain, recovery is slower, and there is a risk of adhesion, which can cause problem later. Laparoscopic Kasai has potential advantages. We get magnified view of portohepatis. There is less trauma, recovery is faster, and the cosmetic result is better. However, laparoscopic Kasai is technically very difficult. The anastomosis quality, the long operative time, and learning curve are all real concerns. I also want to mention some recent publications. 2026 cohort study found no difference between open and laparoscopic approaches. 2023 randomized trial showed better result with open surgery, but 2024 meta-analysis showed advantages for laparoscopic surgery. So the question is still open, and is exactly why our data is important. Our goal was clear. We want to evaluate three things. First, is laparoscopic Kasai feasible? Can we actually do it? And second, is it safe? What are the risks? Third, where the short and mid-term term outcomes, does it work? There are the three questions. We tried to answer this our study. Now let me describe our study design. This was a retrospective study. We collected data from 2022 and 2026, so 4 years our experience. We included 53 patients with biliary atresia who underwent laparoscopic Kasai at our center. The median age at surgery, 74.5 days. This is important. We will talk about age later. We looked at three main outcomes: jaundice, clearance, complications, and native liver survival. Preoperative evaluation before surgery, every patient went through a standard evaluation protocol. The diagnosis starts with classic clinical sign, prolonged jaundice, pale or white stool, dark urine, and poor weight gain. Our poor weight gain, and these are the red flags we must not miss. On ultrasound, we look for a triangular cord sign. This is very important finding for biliary atresia. For preparation, our protocol includes fat-soluble vitamins A, D, A, K vitamins, and urodeoxycholic acid, calcium, lactulose, and DHA and EPA supplements. We also do full bowel preparation, 24-hour fasting, and oral antibiotics like aminoglycosic acid and bowel irrigation. This help us reduce infection risk after surgery. Next slide, surgical technique. When we start the operation, the first thing we do is carefully laparoscopic observation. We look for specific sign, the spider sign, like that, and we look for specific sign, spider sign, and triangular fibrosis and gallbladder. In biliary atresia, the gallbladder is usually very small, hypoplastic, or even absent. Videonu qanaqa qo'ysak bo'ladi videoni? Tepada yana birinchi. This video shows fibrous cone excision at porta hepatis. Next video, please. And this video show anastomosis. Thank you. After fibrous cone excision at porta hepatis, we create the raw and jejunal lymph. This is intestinal part of the reconstruction, and this video show porta enterostomy laparoscopically. Now let me share our result. The median operative time was 205 minutes. This is longer than open surgery, but it is normal for laparoscopic cases, especially during learning curve. We had only one conversion to open surgery. This was due to bleeding, and children started feeding on postoperative day 3, and the average hospital stay was 20 to 25 days. Regarding complication, we observed cholangitis, ileus, sepsis, and bleeding. The cholangitis rate was 43.5%, which is high. But I want to explain this. Most of these cases were in our early period when our postoperative protocol was not yet optimized. The most important result, native liver survival at 1 year of older was 60.5%. The mean more than half our patients keep their own liver without transplantation. This our patient gender is more male, and our operation time, age at operative day, and Kaplan-Meier survival rate, and learning curve effect. One important point I want to discuss is the learning curve. As with any complex laparoscopic procedure, our result improved over time. Our early cases had more complication and longer operative time. You can see that. And as our team gained experience, the operative outcomes become better. And this is comparison with literature. Now let me compare our result with other published series. Our study of 53 patients is comparable in size to many international series. For example, Sherota also reported 53 cases with similar cholangitis rates of cholangitis rates 43%, and native liver survivor of 61%, very close to our result. And Li from China reported 80 cases with cholangitis in 30%, and native liver survivor of 66%. Nakamura from Japan reported better result, 79% native liver survivor, but with different patients selected and disease subtypes. Our results are consistent with the international literature. This gives us confidence. Key discussion. Based on our experience and the literature, I want to highlight our 4 factors that determine success after portal enterostomy. First, early diagnosis, and second point, surgical precision, and third point, multidisciplinary postoperative care or management. Fourth point, cholangitis prevention and follow-up. Limitation. I want to be honest about the limitation of our study. First, the sample size is small. 53 patients is start, but we need more cases to draw strong conclusion. Second, this is single center study. Our result may not apply to other center with different results or patient population. And third, learning curve effect, mean our early results were not as good our center result. This makes the oral data harder to interrupt it. And four, we need longer follow-up. Native liver survival at 2, 5, and 10 years of age. More important than 1 year data. And conclusion, let me now summarize our main conclusion. Laparoscopic Kasai portal enterostomy is feasible and safe in infant with biliary atresia when performed by experienced pediatric hepatobiliary team. With prepared training, the right protocol, and dedicated multidisciplinary care, outcomes can be significantly improved. But the most important message is early referral is the most critical prognosis factor. If we diagnose biliary atresia later, no surgical technique or open or laparoscopic can compensate for the lost time. And future direction, we are exploring robotic Kasai as the next step in minimal invasive surgery. We are interested in AI-assisted imaging enhancement to improve intraoperative visualization, and we are working on establishing centralized biliary atresia center in Uzbekistan. This is currently in progress. We support early stool color screening program, and we are developing a bridge to transplantation strategy for patients whose Kasai does not succeed. and thank you for your attention.
You have a question, please.
If no question from the floor, let me ask you maybe three, maybe two questions. First of all, congratulations for very excellent series and outcomes. Let me ask you, did you compare your experience in laparoscopic procedure with open Kasai?
Thank you for your question. If I tell you that we have not open case, because of that, we don't compare open and laparoscopy.
Okay. What was the next question? What was the length of jejunum loop, which ruined by jejunum loop?
60 cm.
It's possible in child of the first year
We
old.
can do.
Okay, and the last question, where you perform the ruined Y anastomosis? I mean, inside of the abdomen cavity or outside?
Outside.
Outside.
From umbilical port side, we
Okay.
row X, Y, jejunal limb.
Thank you. Dear colleagues, does anybody have questions? No? If so,
I have one question. What was the incidence of postoperative cholangitis?
Cholangitis?
Yes.
I show that our cholangitis percent 43.4% of our cases, and cholangitis rate. Can you repeat the question?
Thank you, please.
Thank you for your question. Very good question. I'm a senior doctor in this department. This is a young doctor. So 43% on initial stages, but we analyzed it and we found we are implemented Japanese protocol of postoperative care of biliary atresia. So we found that we have to keep patient on antibiotics for 1 or 2 years. So patients after Lapkasai receiving antibiotics like cotrimoxazole for 1 year at least. And then we are making the SPAR as a valve. Japanese, especially the Yuntanda Hospital, who has a very huge follow-up, they found that if they keep the patients for 1 or 2 years on antibiotics and on a SPAR, what we do on a Roux-en-Y limb, they have a very less complication of cholangitis. So last 2 years, we keep all our patients on antibiotics for 1 year, and we are making the SPAR on a Roux-en-Y limb. So far, we don't have cholangitis. They are surviving till liver transplant. So we receive other complications like portal hypertension, which is on indication of liver transplant. We don't receive cholangitis for the last 2 years nowadays. But on initial stage, 3-5 years ago, cholangitis rate was 43%, where we don't keep patient on antibiotics and we don't make a SPAR on Roux-en-Y limb. So last 2 years, we don't receive a patient. So we are monitoring them. We don't have cholangitis. Probably it works.
Thank you. You have a question? Thank you very much.
Thank you.
Please.
Let's move to the next speaker. It's my pleasure to invite on the floor Dr. Dusmurodov with the talk Abernethy syndrome in children, diagnostic approach and surgical management. You're welcome.
Good morning, distinguished colleagues. Let me start my presentation. It's a great honor to present our work on the diagnostic approach and surgical management. of the congenital portosystemic shunts, Abernethy syndrome, based on the experience in the National Children's Medical Center. Why Abernethy syndrome matters? Let me begin by framing why this rare anomaly deserves our attention. Since John Abernethy first described it in 1793, however, then 200 cases have been reported worldwide. Despite its rarity, the clinical stakes are high. 50–60% of type 1 patients carry associated cardiac defects, and the condition is frequently missed because its onset can be entirely asymptomatic. Classification. The turning to classification will follow the Morgan and Superior system from 1994. Abernethy syndrome, or congenital extrahepatic portosystemic shunt, is divided into two fundamental types based on portal vein anatomy. You can see in this slide. The next slides I should stay shortly because in the next slides, based on international guidelines. This slide, we can see the pathophysiology of the Abernethy syndrome. The next slide, we can see clinical presentation by age. Our diagnostic algorithm proceeds through five sequential steps. It begins with clinical suspicions triggered by hyperammonia, cholestasis, cyanosis, or an incidental findings. Mostly, we prefer the CT. In the next slide, we can see laboratory and imaging investigations in patients. And in the next slide, we can see surgical management algorithm based on the international guidelines. In the next slide, we can see case number 1. Let me to illustrate this with our first case. A 3-month-old male was admitted in November 2025 with jaundice. Laboratory findings showed bilirubin of 127.6 and transaminase ALT of 183 and AST of 100. On the CT revealed a type 2 large intrahepatic portosystemic shunt up to 25 millimeters in diameter with hypoplasia of the right hepatic lobe. We proceed with endovascular shunt closure in 110 minutes procedure with only 12 millimeter of blood loss. By postoperative day 7, bilirubin had fallen to 39 and transaminase had normalized substantially. At 5 months follow-up, bilirubin was 3.4 and with ALT and AST essential normal. The patient remains in good clinical status. Here you can see before and post-operative CT. In this slide, you can see our second case involves a 4-year-old patient admitted in September 2025. Initial labs showed, here you can see bilirubin was 27 with mild transaminase elevation. In the angiography confirmed the shunt, and balloon occlusion testing measured a portal pressure of 18, well within the safe range of closure. In October 2025, we performed ligation of the ductus venosus, the Arancius ducts, 140 minutes procedure. At 5 months follow-up, the patient is doing well. We can see the video. Videonu koyuyorum. So, in the second case, we did open surgery. We performed ligation of the ductus venosus. You can see the video. After ligation. In the last year, we did 2 cases with Abernethy syndrome. This is our team. After 5 months, the 2 children in good clinical status. Thank you.
Thank you so much. The topic is open for discussion. Any questions from the floor? If no, let me ask you, what is the total number of patients with Abernethy syndrome in your experience?
2 cases.
2 cases only.
Yes.
And both cases were with preserved blood flow in the trunk of the portal vein, as I understood, no? You mentioned that there are 2 types, with occlusion of portal vein and with no occlusion. Both patients with no occlusion of the trunk of portal vein.
Yes.
Okay. Mhm. Is there any other questions? Thank you again.
Extrahepatic portal hypertension in children. Rationale for the choice of port system. Okay. Anvar Jurayev, Özbekistan, please.
Good morning, everyone. The topic of my presentation today is extrahepatic portal hypertension in children, rationale for the choice of portosystemic shunting. I would like to share our department's experience, the Department of Minimally Invasive Surgery and Transplantology, in the diagnosis and surgical management of this condition. Let me begin with the pathophysiology. Extrahepatic portal hypertension begins with portal vein thrombosis, leading to obstruction of portal blood flow. This followed by cavernous transformation around the occluded vein. Next, portosystemic collaterals form esophageal, gastric, splenic, and periumbilical, bypassing the obstruction. And it leads to variceal bleeding, hypersplenism, splenomegaly, and gross retardation, fatigue, and poor quality of life. The most common cause in our center was portal vein thrombosis. And the most common clinical manifestation was recurrent upper gastrointestinal bleeding, massive splenomegaly, thrombocytopenia, chronic anemia, and melena. Moving on to diagnosis. The first line investigation is Doppler ultrasound, which demonstrates the absence of portal vein flow. The confirmatory study is CT photography, which provides detailed anatomical information. Also, in our department, we routinely perform rigid hepatic venography, a technique which allows us to access the patency of the intrahepatic portal vein, which is the key determinant in choosing between a mesorex bypass and a non-physiological shunt. Here you can see how we do rigid hepatic venography in this video. This slide shows and indications for surgery. Also, endoscopic treatment plays an important role. Surgery becomes necessary in patients with recurrent variceal bleeding, failure of endoscopic therapy, severe hypersplenism, or significant impairment of quality of life. Based on our experience, we follow this decision-making algorithm. In a child with extrahepatic portal hypertension, the first step is to determine whether the intrahepatic portal vein is patent. If yes, the mesorex bypass is a treatment of choice. If the intrahepatic portal vein isn't patent, a non-physiological portosystemic shunt is performed. It may be splenorenal or mesocaval, and it's selected based on anatomy, prior surgeries, and surgeon experience. The available shunting options fall into two groups. The physiological shunt is the mesorex bypass. It connects the superior mesenteric vein to the left portal vein and preserving hepatopetal liver-directed flow. The non-physiological shunt includes the distal renal shunt from the splenic vein to the left renal vein, the proximal renal shunt, portocaval shunt, and which is rare in children. The mesorex bypass is a physiological shunt in which an anastomosis is created between the superior mesenteric vein and the left portal vein at the rex rectus. Its advantages include restoration of physiological hepatopetal flow, preservation of normal liver perfusion, and the best long-term outcomes in children. When a rex bypass isn't technically feasible, the alternative is the splenorenal shunt, an anastomosis between the splenic vein and the left renal vein. It effectively decompresses the portal system and controls variceal bleeding, but doesn't restore liver perfusion and alter the natural blood flow. Now let's turn to our own clinical experience. From April 2025 to the present, our department has managed 10 patients with extrahepatic portal hypertension. 5 underwent surgical treatment, representing a 50% surgical rate, while the other 5 underwent diagnostic procedure. It was widget hepatoportal widget diagnostic. And among 10 total interventions, 3 was distal splenorenal shunt, 1 rec shunt, 1 endoscopic vertical ligation, and 5 diagnostic angiography with photography procedures. Case number 1, patient was born in February 2015. Imaging revealed marked splenomegaly and extensive collateral venous circulation in the upper abdomen, predominantly in the perisplenic region, consistent with portal hypertension. The abdominal aorta and major visceral arterial branch were patent. Surgical portosystemic decompression was indicated, and on April 2025, Warren shunt was performed. This slide shows the intraoperative view of the completed Warren shunt and Doppler ultrasound confirming patency and adequate flow through the anastomosis in the early postoperative period. Follow-up contrast in case after discharge, all our patients undergo routine follow-up with Doppler ultrasound at 1st, 3rd, 6th, and 20th months after surgery. At the 20th month follow-up, in this patient, an elevated resistive index was noted, prompting further evaluation with CT angiography to assess vascular patency. Follow-up contrast enhanced CT angiography on May this year demonstrated stenosis at the splenorenal shunt anastomosis. On June 10th, this year, balloon angioplasty of the shunt anastomosis was attempted. However, the stenotic segment couldn't be transferred. Despite multiple attempts, and angioplasty couldn't be performed. The management plan therefore consists of clinical follow-up and surveillance, together with endoscopic esophageal vertical ligation, and this case demonstrates that even a technically successful shunt may require complex further management, including situations where endovascular correction isn't feasible. Next case, it's a patient which was born in 2020, presented with portal hypertension requiring surgical portosystemic decompression. And in August 2025, a Warren shunt was performed. The procedure was completed successfully with an eventful postoperative recovery and no early complication. The image showed dissection and mobilization of the splenic vein and exposure of the left renal vein. Here we see the preparation of the Warren anastomosis and the completed distal splenorenal shunt. Case number 3, patient which was born in 2022. A Warren shunt was performed on September 2025. During diagnostic catheterization on November 2025, an occluded splenorenal shunt was identified, and the cannulation attempt was unsuccessful. This case illustrates the problem of late shunt occlusion requiring further management decisions. And last case, it's patient which was born in 2024 with a diagnostic of portal hypertension. On November 2025, a mesoportal bypass rec shunt was performed, representing the physiological shunting approach. This slide shows the key surgical steps: mobilization of the left gastric vein and formation of the anastomosis to the rex rectus. Follow-up contrast enhanced CT angiography in this patient, which was made in May this year, showed the mesoportal shunt pattern throughout its course, with contrast occupation observed along its entire length, and a measured shunt diameter of 2.98 millimeters. There was no evidence of thrombosis or occlusion. Collateral circulation was reduced compared to the preoperative state. These findings indicate satisfactory postoperative shunt function. And in conclusion, I would like to highlight several key points. Extrahepatic portal hypertension is a vascular disease with preserved liver function. The Mazarex bypass is a treatment of choice in selected patients with technically feasible. Shunt remains an effective alternative, and the surgical strategy must be individualized for each patient. I would also like to highlight our follow-up protocol after Mazarex and Warren shunt procedures. Its Doppler ultrasound is performed in the early postoperative period, then at first, third, 6 and 20th months, and annually thereafter. CT or MRI angiography is performed as indicated. Long-term antiplatelet therapy is also prescribed with individual adjustment of antithrombotic treatment. Thank you for your attention.
Thank you. You have a question?
If no, I have two questions. Could I ask you?
Yes.
May I pay attend your attention? Thank you for your very nice presentation of very challenging cases, especially pediatric. Did your patients experience hepatic encephalopathy after distal splenorenal shunts?
No.
No.
Our investigations was from the 2025 year. So for this time, encephalopathy we didn't indicate it for
Okay.
now.
Thank you. And the second question is, did you administrate the antithrombotic therapy, chronic antithrombotic therapy for all your patients? Or no?
Yes, we did. In early postoperative time, it's between 24 and 72 hours after operation, we begin our anticoagulation and antithrombotic therapy.
Okay, thanks so much. Dear colleagues, the program of our section is closed. If no any comments, thank you for everybody.
Айрифанов, мы вас поздравляем. Большое вам спасибо за то, что вы приехали и вот в течение 4 дней нам показали свое мастерство, общались с нами и дали советы нам. Большое за это вам большое спасибо. И думаем, что мы в дальнейшем будем с вами сотрудничать и много раз еще будем увидеться на таких конгрессах. Это сертификат вам. И небольшой приз от Узбекистана, чтобы вы помнили, что были в Узбекистане и в дальнейшем еще планировать приехать туда на наш конгресс.
Thank you so much. It's my great pleasure to be here, and it's really honor to be part of the Uzbekistan society, and not only Uzbekistan but our Turkish colleague, because it's a great experience to have a chance to conversate, to deal our experience, share our knowledge. That is very, very special and very successful meeting, and I am proud to be here. Thank you so much.
Dear colleagues, we have plenty of time, but if you want, we could start with the next session to have more time for discussion. For me, it's a pleasure to invite on the floor Professor Dogru from Turkey to present his topic, pancreatic cysts, current tools and differential diagnosis. Please, the floor is yours.
Thank you very much. Morning, chairs and dear my colleagues. Today I will discuss the current tools used in differential diagnosis of pancreatic cystic lesions. But please keep in your mind that the main challenge is not detection of the cyst in the pancreas, but the main challenge is to decide which patient must be surgically treated or maybe followed safely. In next 15 minutes, I will briefly mention about the clinically relevant pancreatic cysts, discuss the limitation of conventional diagnosis, introduce new emerging US-based tools, and explore how these tools influence surgical decision-making. Why these cysts matter? Because the increasing prevalence due to widespread use of MRI and CT examination, most these cysts are discovered incidentally. But the main challenge here is fortunately, majority will never become malignant, but some represent real precancerous lesions. So we must avoid over-treatment, while we must not miss high-grade dysplasia or invasive cancer. A practical approach is to classify cysts according to malignant potential, such as non-neoplastic pseudocysts, benign or nearly benign serous cystadenoma, pre-malignant and potentially malignant lesions. Our main challenge is, or we mainly deal with these four type of lesions: main duct, branch duct, mucinous cystic neoplasms, and cystic neuroendocrine tumors or solid pseudopapular neoplasms. As a surgeon, we have to identify which patient needs surgical treatment. Currently, the diagnosis begins with detection of cyst on CT or MRI, and we look MRI or MRCP for communication with presence or absence of communication with main pancreatic duct, presence of septations, mural nodules, and cyst size and location. And depending on these findings, we stratify the risk of the patient. If patient have high-risk stigmata, we mostly refer the patient to the surgery. But otherwise, we need some additional evaluation. For this, endoscopic sonography is the mainstay of diagnostic tool in this step. By means of this technology, we obtain fluid sample, sometimes tissue sample, and for cytology and some evaluation of some biological markers, it helps us. So as a result, after getting these results, we discuss the patients in multidisciplinary tumor board. What are the limitations of conventional diagnostics? Most of the lesions imaging features may overlap between each other. So current diagnostic tools may have limited sensitivity in terms of imaging features. So also cytology is mostly yield inadequate cellular structure or tissue architecture. So its sensitivity is really low in most of the patients. And as a result, up to 1/3 of the resected cysts prove low risk, but some malignant lesions are missed during the initial evaluation. What is their clinical impact? So we do uncertain risk assessments, inappropriate surgery for some patients. In some patients, we delay treatment, and it cause high healthcare costs. And so what we need is better biological characterization before surgery. Currently, depending on our clinical guidelines, if patients have high risk stigmata, we directly refer the patients to surgery. And if they have worrisome features, we need further evaluation. And the current further diagnostic tool is endoscopic sonography. ERCP is mostly not used in diagnosis of cystic lesions, but in case of obstructive jaundice, we may do, and this is the MRI image of a main duct IPM, and on the picture left upper side, you see filling defect in main pancreatic duct. And the next picture on the middle of the screen, upper side, typical appearance of fish mouth papilla is pathognomonic finding for main duct IPMN. And this, the picture on the right side, upper picture on the right side, you see string sign obtained by obtained liquid material from the ERCP. You see the string sign. Although we use MRI, CT, or US in evaluation of these patients, some have additional advantages in relation to other one. CT is mainly used if you decide to do surgery to evaluate vascular anatomy. Otherwise, MRI is the best modality for surveillance of patients. If you decide follow-up of the patient, MRI is the best option. And endoscopic sonography is best for mural nodal detection, evaluation of septal evaluation, and detecting the multifocal lesions. And also it gives us a chance to get fluid sample or tissue sample during the procedure, and also tissue for molecular analysis. Currently, we firstly check for carcinoembryonic antigen level in cyst fluid, and if it's higher than 1.2 nanograms per milliliter, it has a sensitivity of 70 to 80% for diagnosis of mucinous cysts, not malignant cysts. If CAA level is high, it means the lesion is mucinous lesion, but it doesn't mean that it is a malignant lesion. And currently, glucose is an emerging marker for also diagnosis of mucinous cysts. If it is less than 50 milligram per deciliters, its sensitivity is higher than carcinoembryonic antigen in terms of diagnosis of mucinous cysts. And amylase levels are also routinely checked, but it means that it is a pseudocyst or the lesion have communication with pancreatic duct. So to make it more sensitive, the fluid analysis more sensitive and specific, new technologies are developing or developed currently. Through the needle biopsy technique is a relatively new technique. So by microforceps deployed to obtain a core of tissue through the biopsy needle, so it gives us a chance to obtain tissue from the cyst wall or mural nodule wall, and it supplies us a histologic diagnosis, a grade of dysplasia, and a sample for molecular profiling, and improves our clinical decisions. So diagnostic accuracy is significantly higher than simple fluid analysis, although this technique has some complications, such as the acute pancreatitis is the most commonly seen one. Around 10% of patients may have complications, but this technique increases our diagnostic accuracy. For molecular diagnostics, these are one of the new frontier subject in this era. KRAS and GNAS mutations are the initiating mutations of mucinous cysts in development of an invasive cancer. But again, the presence of these mutations doesn't mean the lesion is the malignant lesions, but it means that they are mucinous lesions. Especially KRAS is specific for mucinous cystic neoplasm, and GNAS or GNAS lesion, mutation is specific for IPMN. But if the other mutations seen in red color on the middle picture, if present, they mean that there is advanced neoplasia or even invasion or invasive cancer or pancreatic cancer in the patient. If these mutations are present in molecular profiling, these are associated with increased risk of malignancy. So another technology used in differential diagnosis of cystic lesions, needle-based confocal laser endomicroscopy. I have seen for the first time when I was preparing this presentation, in fact. So again, a laser light source is deployed through the needle, biopsy needle, and it takes obtain a image from the cyst wall, depending on the reflected light, and it may have some different patterns, such as Pearl-bed pattern is specific for serocystadenoma, and papillary projections, if you see, it is pathognomonic finding for IPMN, and if you see epithelial bands, it's typical finding for mucinous cysts, and if you see acellular space, the patient most probably have a pseudocyst. So by combination of through the needle biopsy technique, this technique may have 100% sensitivity, specificity, accuracy, and negative predictive value. For mucinous cysts, diagnostic performance is around 95% for this technique. Finally, AI is the next frontier, of course, as in all era of the medicine. AI can integrate imaging and sonographic features, biomarkers, and molecular data into a single predictive model. And this model helps us personalize risk assessment and precision management. An experienced clinician have 56% accuracy, but AI have 95% accuracy in differential diagnosis of making a precise decision for the patient. So, as a result, I can say that most pancreatic cysts are benign lesions. MRI and EUS remain the foundation of pancreatic cyst evaluation. Morphology alone is not sufficient to make differential diagnosis. glucose is emerging as highly practical biomarker. Molecular testing is becoming essential for risk stratification. TTNB and NCLE provide additional diagnostic precision, and the future paradigm is integration of imaging, US findings, biomarkers, and molecular biology and AI. And better diagnosis means better surgical selection and fewer unnecessary resections. So the last sentence is imaging shows morphology, biology shows behavior, and AI helps to make our final decision about the management of our patients. Thank you very much for your attention.
Thank you, Professor Gürgül, for this excellent and very well structured analysis. Does it arise some questions from the audience? If no, I would like to ask you some questions regarding the surveillance schedule of surveillance of incidentally founding cyst. What is the practice in your department?
We follow these patients with MRI annually. And how long do we have to follow these patients is a debate of matter of debate. And currently, it's advised at least 5 years of follow-up for these patients must be performed. But at the end of 5 years, you must discontinue to follow up these patients if there is not development of high-risk stigmata or horizon feature or anything else. You must stop surveillance of these patients. Currently published in JAMA surgery last month. Also 5 years is the final date for this patient.
Yes, because most of the lesions requires lifetime surveillance.
Yes.
But at the beginning, what is the frequency of MRI in your institution? Every 6 months or every year?
1 year annually.
Annually.
One per year.
And the second question that I would like to ask you is if you have a synchronous cystic lesion and pancreatic ductal adenocarcinoma, have you chasing radicality in every patient, or you decide individually to do pancreatodynectomy or total pancreatectomy?
Every cyst lesion have individualized risk. So you must decide on resection of all individual cysts depending on the cyst characteristics for all cysts, independent from other ones. So total pancreatectomy may be not always necessary, but in main.IPMN, we routinely perform frozen section from the cut surface of the pancreatic tissue, and if there is high-grade dysplasia or invasive cancer, we perform additional 2 centimeter resection of the pancreatic stump, and if there is still these findings we obtain, so we perform total pancreatectomy. Otherwise, people procedure is enough for main.IPM in our routine practice. We do.
Okay, thank you very much. Are there more questions? Thank you.
Thank you.
Hörmətli konqres iştirakçıları, Azəri dilində bu imkandan istifadə edilməm və ikinci panelin başlamasından qabaq, ikinci məruzəçiyə söz verməmişdən qabaq. Söz verməmişdən qabaq, istəyirəm imkandan istifadə edib bu gözəl konqresi təşkil edən təşkilat komitəsinə və onların rəhbərlərinə, Professor Mustafa Kərəmə və Professor Oktyabra öz Azerbaycan nümayendeleri adından büyük minnettarımı bildiririm. Güzel bir kongresimizin son günüdür. Ona göre de yürekte olan dolu sözler çoktu. Ben hamıya hoş arzular dilerim. İndi ise icazə verin sözü deməli bu mövzuda high risk intrapapular buccinoplastom and surgical decision making presentation Erdem Kinaçı, Türkiye.
Erdemcim duyabiliyor musun bizi Doktor Fatihcan?
Duyuyorum.
Tamam. Oturum başkanımız seni anons etti. Sen başlayabilirsin.
Biraz geç geldi.
Onlar bir.
Dear chairs and my colleagues, first of all, I would like to thank the organizing committee for the invitation. Apologize for inability to attend to the unfortunate circumstances. Today, my topic is high impact and transmission of genetic. Actually, the global of the issue and some part of my presentation will cover slide. I will try to do this. Sharing experience as a surgeon or intelligence regarding the issue quite challenging because again, as a brother, there are many parameters.
Erdemcim affedersin. Şu an biz slaytları değil seni görüyoruz. Acaba onu düzeltebilir misin? Ekran paylaşımından slaytları alabilir misin lütfen? Sol alt köşede kendi resmin var. Onu kaldırırsan tamam. Slide gelecek. Full screen yapar mısın? Tam ekran. Tamam, şimdi devam edebilirsin.
Sharing is a social community practice issue. It's not easy because there are complications and affecting there are many complications affecting the management of the disease. And both patients over years are trying to expect based on the extensive documentation. The issue of IPM and social decision-making is quite complex and start with the definition that the population is first this type in 1994 as a close advice to introduce the popular executive. There are not only from special has been widely accepted. These are lifestyle IPMs communicated with the main issue. In main IPM includes type of these two types. With the advanced imaging technology and the advancement of the detection of the pancreas, according to the meta-analysis published in 2024, this rate varies between 14 to 18%. Of course, the increase in the imaging success can lead to other detecting some of the spaces and making them better than consequently performing demonstration. The progress in the non-restricted approach. The market survey has a mortality and morbidity, increasing the very households, and significant psychological problem for patients. And the main question in patients with IPM is which IPM should be exactly. To address this question, expansion to understand the relation between IPM and which individual lesions are at risk of progression. The pancreatic cancer developed by two primary perspective pathways. One is pancreatic intellectual lesion, so-called PANIS, is out of our support today, And intraductal insulin plasmas, this is our topic, and clinically wise development of modifications. All of those information genetic mutation, but this is down approach can be integrated. I can count the division of this sequences developed in the last year. I can be long way to high state especially silver types are also related to the rate of the area. And gastric type, I can challenge low rate area. Why it's on the especially pancreatic type, especially with high grade acidic, even with cancer. This does not mean that carcinoma is completely wrong. This type is a risk factor for the normal type. In genetic examination, first of all, talk about is the KRAS gene mutation are very important. But in last year, the three-way to local cancer is described. One of them is de novo carcinogenesis. In this type of carcinogenesis, it's the way that the people you cannot find the direct correlation between the pipeline and the cancer. I showed you the special type of pipeline and gastric type tests that are going to be there. The second question is which individual are at risk of progression to cancer? Actually, the morphology is the first thing we understand. The main type cancer is a very high risk of showing a high degree of dysphagia and colon cancer. But which type carries these risks at a critical rate. Why do I say critical rate? Because 30% risk of high grade dysphagia and 20% of liver cancer are not low rates that can be ignored, but they also don't seem to be sufficient reason to operate on all of the cases they will find. How about this type of epidemic? It's another complex issue because it has been called that some cities called the mixed type of this beginning of the program. The mixed type only batch type is in the case of mixed type, using the very it's a complicated, especially beginning of the program. To answer the question, who should be rated more? The first guideline was published by the National Institution of Pankreatology 2006, and it continued with revisions in 2012 and 2017 and more in 2012. And there are another guidance from Europe and America. But one of the most detailed guidance investigation which was published by the International Institution and widely guidance about this issue. In first version of the guidance, the lesions were related to two main groups of this without iris phenomena. And the first big version of the guidance is primary concentrated protection. By 2012, while surgical intervention is still primarily recommended for male academic, as separate from the course of patients with surgical protection, this is called high risk. The endoscopic sonography was available for this personal issue. There is an interesting thing in this algorithm in 2012. At the end of the final section, because the algorithm, we see that any medications can still be interpreted about the guidance. you can cover everything with this guide. In 2017, minor revisions to 2012, and prediction was a question of I had to suggest very simple to global of IGN has little bit changed in this version. In that time, we significant data project to be collected on this topic. One of the most valuable is was understanding both neural networks. And neural networks are described in 2012 packets. They bring significant inversion data. In 2018, from more than 2,000 cases, which between 500 cases were published. The most notable visual of the data is one that all case numbers just only they do not for threshold for numbers dimension because the data of high heterogeneous. In looking at the motorway analysis of this meta-analysis, it's into that the value the movement of high specific for branch and main. If you talk about the development of this slide, concept about it's crucial for market disease today. And it was originally used in many centers. But this, there are some limitations about the movement plus. There are some questions coming up mind. Can limitation be able to is very and so first of all, talk about some examinations about because they usually political data can be examined from bias and inspection bias. In molecular genetic evaluation, next generation sequence can be able to diagnose of mutation, especially in KRAS genes. Citations and censorship analysis is another important issue because the morphology is not enough to design survey. You have to show the high rate generality of the stage to decide the surgery or sometimes should be defined in social analysis. We have to talk about movement because this is complex exercise in pattern recognition. So, and those represented findings should be results for patients who move the result with direct out of the information decision. The analysis is not an excellent for all the recruits. Today, in last years, the last version of the
Erdem, bizi duyabiliyor musun? Erdem, duyabiliyor musun? İnternet bağlantısına bakabilir miyiz arkadaşlar? Bizden mi kaynaklanıyor acaba? Oradan mı? Evet. Tekrar bağlantı kurmayı deneyebilir miyiz? Can we try reconnection, please? Arasana. Bir arar mısın Erdem'i? Ne oldu Cihan? He, he's trying to reconnect now. Just we are asking from you a few minutes to continue. Ee, Erdemciğim bizi duyabiliyor musun? Lütfen slaytları tekrar paylaşıma açarsan. Lütfen, evet. Full screen yapar mısın? Devam edelim lütfen.
I'm sorry for this technical problem. I was told about the newton. It's again the high system and vertical features. Other departments that they have the definition. New parameters related to the use of everything is mentioned in the highest system. At the beginning of work, if you have performed a and high rate station of the vertical capacity, this is also the highest. And surgery by command. In vertical pages, are the development indication of identity small performance in the body. And go exceeding 1.5 between 1 year and meters. The risk in stabilization in the number of vertical features present. If the patient has more than one vertical feature, that means the risk of malignancy is high. In this situation, the patient should undergo surgery for this slide. The surgery will be treatment. What kind of surgery we have to do in this type of patients? The molestation type, suspicion of molestation patients are important to decide the resection type. The primary goal is to hide the tissue by getting as much of it as possible. You know, there are standard resections for the location of the patient, process resection is not if you have enough suspicion about the vulnerability, you have to perform multiple resections like the particular person. The should get a suspicion because of person. Actually, in general, the top is not common because it has a high level of work on this information, suspicion of we are going to talk about the what about the first section, which was really resections? Surgical margins is be surgical margins will be examined in resections for 5 minutes. High pressure will be detect the high pressure will cancer in the surgical margin. Additional rotation total if the margin has low anesthesia, no need for additional resection, rather close to the northeast territory. There's no in the line search for margin at this point not instead of margin, additional actually is also needed. And in summary, Joe mentioned this big proverb, but it is shaped reflects better risk rather than and surgery. We now have more data to identify to identify surgery as they are great and look at the topic plays the key role and the however, it should not be present for every competency. And should be more given the value expected remaining. And the primary goal of surgery is the people of higher institution while doing the function as much as possible. Items can be related to the non-flexible. So surveillance should be implemented over this limits. Thank you very much. And
Thank you very much for this nice speech presentation. Okay, colleagues, do we have any question to Dr. Kınacı from the floor? Anybody? Question? No? May I have two questions for you, Dr. Kınacı? First one, do you believe we can adopt one of guidelines which are, we many guidelines now published. So do you believe we need to strictly adhere to one of the guidelines, or can we individualize our follow-up strategy, combining, for example, two recent guidelines? What do you think about institutional individualization of follow-up? This is the first one, please.
Yeah, general, the guidelines are the only guides. So the guidelines, the algorithms and the guidelines cannot be excellently applied by the patient because it's rigidity, methodology, your catchments, your technical potential, the experience in some kind of modality, like in Turkey, we have lots of switch for folks, and so follow up with them on our system. For example. Or in psychological problem also in different problems. So I think the guidelines should be used as a only guide.
Okay. The second one is you highlighted twice that the EOS guided biopsy should be reserved only for patients in whom the EOS guided biopsy will change clinical decision making. In your clinical practice, how do you use EOS guided biopsy? Do you perform liberally EOS guided biopsy, or how it changed your clinical decision making?
If you perform all operations like surgery and you are a lot of surgery, a lot of this as a surgeon, you can do something in your area. So I think in the is useful, but in the aspect of investment or the pathologists who will examine your slices. So if you look at this type, this part, the endoscopy is not an excellent result. In some cases, endoscopy reports are not really standard. Can they come data about system, but you cannot find anything, and it's an intervention. So the patient you cannot perform again. So if you have a suspicion, I'm in fact in my practice, they will come up, and I told my radiologist for each case, and we have enough suspicion about the malignancy, risk of malignancy. Then we do perform sonography, and before the endoscopy, we also talk with my endoscopist, and he said for each said this is reachable, can be performed easily. It's not standard.
Okay, we have one question from the floor, Dr. Mustafa Kerem.
Actually, it is not a question. It is a comment, short comment. It is our practice in Turkey. The EU endoscopic ultrasound, unfortunately, using more than enough by gastroenterologists. Even 1 centimeter diameter in simple cyst, the gastroenterologists try to perform to the all cysts to the EUS. It is very bad practice for us. Even many times we discussed them. The EUS indication just when confused one cyst make us. This is benign or malignant. Yeah. We have to make decision together. Pancreatic surgeon and gastroenterologist should be together make decision endoscopic ultrasound. Another problem in Turkey, they are sampling, especially biochemical analysis is 1990, CA 1990 now. It is very big problem. Even very small cyst and has very high 99 level in biochemistry. It is very confused patients, relatives, gastroenterologists. It is unnecessary. So finally, it is my comments. As a pancreatic surgeon, we should make decision EUS indication. Erdem, very nice presentation. Thank you again.
Okay. Thank you very much.
I totally agree with Professor Kerem. We should be more liberal with pancreatic cyst nowadays. We have a lot of tools for non-invasive imaging, so we should wait for endoscopic ultrasound and especially for fine needle biopsy. So thank you very much. Now we will proceed with the most interesting part of our session, case discussions by Professor Buyuk Kasap and Gonca.
Dear chairs and dear participants, my name is Çağrı Büyük Kasap. In this session, together with Professor Erdem, we will discuss 4 cases with you over the next 30 minutes. Okay, we can start with the first case. Our first case is 72-year-old male patient who was evaluated after a suspicious pancreatic mass was detected on imaging. The patient had multiple comorbidities and was taking several medications. His laboratory was normal. On thoracic CT, the dilatation of the pancreatic duct was detected. On abdominal MRI, the pancreatic duct was again found to be dilated. measuring 90 millimeters. On abdominal CT, the pancreatic duct measured 15 millimeters, and the findings were interpreted as main duct IPMN. We will now reveal the radiological images.
Can you switch to my screen, please? Hi again. Particular to this case, CT will not give us many things, so I'll just start directly with the MRIs. So starting with the two images again, we see dilatations in the whole pancreatic channel, but when you look closely just by T2, you see some millimetric, cystic, other parts. But the main thing here is they first reported as a cystic dilatation of the main duct, but you see it's irregular around 2 centimeters. He called it as 19 millimeters, doesn't matter. And also it has multiple extra millimetric cysts around it. Looking at the contrast enhanced images, on the upper part, you see the venous face, and we only have a subtracted arterial image here, unfortunately. We don't see any particular enhancement here within the walls or like septa-like parts. But the main thing here, when we look at the MRCP images, again, this is the raw image. I will switch it to surgeon-friendly later. You see there are multiple cysts with the side branches. Among these, we have a lobulated cystic dilatation, which is not actually the main pancreatic duct. So we would have interpreted this as a main duct IPMN question mark. This is the MIP images. You can see this is the main bile duct, the pancreatic duct. Because the raw images are hold on together, you will see them like combined. But actually, what you need to do is go back to the raw image, and you will see that these are all different, separated from each other. Okay, so you should not be confused by this image.
Okay, thank you, Professor. At this stage, what would be your next step? Would you proceed direct to surgery, request further imaging, or prefer follow-up?
You can.
Is there any recommendation?
Mustafa Kerem.
I want to ask you all, do you want to do EUS for this patient? Is there any indication as a pancreatic surgeon? Fatih?
I mean, I would talk twice with my radiologist. If this is a main duct IPMN,
yeah,
I would directly proceed to surgery.
There is a direct surgical indication and no need EUS, right?
Yeah, absolutely.
But any other opposite thought from the floor? Everybody goes directly to surgery.
Yeah, for surgery, we can.
Çağrı, can you please explain what?
Okay,
So what
at
happened
this stage, the team decided to proceed with surgery, like you, and a preoperative risk assessment was performed. The charts and comorbidity index 7 and ASA status was 3. At this point, would the patient advanced age and multiple comorbidities influence your decision? Surgery or follow-up now?
Surgery.
In these heavy conditions, I could propose the surveillance after 6 months.
Okay, sir. Okay, the team decided with subtotal pancreatectomy and splenectomy. Frozen section analysis showed no evidence of malignancy or IPMN at the surgical margin. Final pathology revealed mixed type IPMN with high-grade dysplasia identified in multiple foci. At the third postoperative year, follow-up MRI showed no pathological findings.
I think there is a
Sayın.
very nice clear-cut take-home message in this patient. It's very important. The main duct was dilated at the beginning because of mucin. It was not because of IPMN. Right now we are seeing that it became narrower afterwards, after the surgery. That means not every dilated duct is a main duct IPMN. This patient had a mixed up IPMN on the corpus and until the next side, and after the surgery, it became better. That's
Okay.
it's a nice take-home message. Like,
I want to ask Gonca, when we look at the retrospectively to the MRI, would you tell us where the cut of surface of the pancreas would be? Yeah, I mean,
Distal as surgical.
yeah, because you know the very distal part of the main duct
Can you switch to my
No.
screen again?
is normal, and pathology reveals
Well,
there's no high-grade dysplasia there.
For me, it's not normal. The main concern with us would be it's not smooth. It's irregular and having mixed up. There are also side branches that I see.
I mean,
side branching.
You
side
believe we
branches.
should we should have gone to a total pancreatectomy?
No,
You mean-
we would say because
Okay.
we see that there is the. Can you see that here?
this is
This
not
is
the
the-
decision of the radiologist.
That's what I'm telling you.
This must be the decision of the surgeon together with the pathologist. Yeah. And this is homogeneous and
You see them hyperintense, but we would not. The main thing mostly will your surgeons ask for us, is this like a chronic pancreatitis? Something like a chronic pancreatitis, but for us being lobulated, and you see it's different than here. You have another dilatation and other cysts, and on the distal part you have other dilatations. So this is not.
Firstly, can you just switch it to this surgeon-friendly
Yeah.
mode? Yeah.
If you want.
You see it is perfect. I think
Yeah. That's
at the
what
head side, this is
this is important. This is maybe the second take-home message.
Yeah.
Because you should have decided where to cut the pancreas beforehand. So we see there the distal part of the Wirsung canal is normal. The deceased part is on the body, the tail of it,
Yeah.
right? That's what I'm
Yeah.
asking. Okay. Çağrı, okay.
Okay.
Go ahead.
We have some take-home messages from this case. Marked main pancreatic duct dilatation should not be underestimated. Comorbidity should influence risk-benefit assessment, but should not automatically preclude surgery. Frozen section assessment of the pancreatic margin is essential. Long-term postoperative surveillance is still required. We can continue with our second case. Our second case is 67-year-old female patient. She presented to hospital with a complaint of cough. During thoracic imaging, a suspicious lesion was incidentally detected in the pancreas. Her laboratory parameters within normal limits. Thoracic imaging reported a 3 centimeter suspicious lesion located in the pancreatic end. As we know, abdominal pathologies may sometimes be overlooked on thoracic imaging. However, in this case, the finding caught the radiologist's attention. Based on this finding, the team proceeded with the abdominal imaging. A 3 centimeter cystic lesion was identified in the pancreatic head. The lesion was found to communicate with the main pancreatic duct. The main pancreatic duct, 10 millimeters. We can review.
Can we switch to my screen? So this is the first thoracic CT. Well, a decent radiologist should not miss this because it's huge. Like, okay, some millimetric lesions can be missed, but this should be cut like for every radiologist. So we have it finishes here. So we have a cystic not cystic, we would report it as hypodense lesion and would suggest an abdominal MRI and MRCP, eventually which was done. So again, looking back at the T2s, here you can see that the pancreatic channel is dilated, and in the head you can see the lobulated with septum, with septa, the cystic lesion. What we do is directly we need to look at the contrast enhanced images, whether we can tell you this is the septa are enhancing contrast or not. So I need one non-contrast image and then the following arterial and venous phases. Sometimes it's not that simple. Mainly we need good screens for that. So maybe you won't see you will not agree with me that this lesion is enhancing, but it is, trust me. So I'll show you side by side. So this is the non-contrast image. Okay. Take a look at here. There's a tiny septum here. And when I go to the venous face, you can obviously see it's enhancing. Okay, it's the same area. So the second thing we do, we want to know whether it's the its relation with the pancreatic channel. Again, I go back to T2, for us it's very easy. You can see directly here the communication. And also, I think we have another simple cyst here. I don't know whether it's relevant or not. So we would report this as a cystic lesion with contrast enhancement in the septum at the head of the pancreatic head. Maybe you want to see the MRCP. I don't think we have the MRCP for this. Yeah. We don't have the MRCP images.
Thank you, Professor. Okay, what should we do at this stage? Would you prefer surveillance, further imaging, or surgical treatment? No diabetes.
Actually, I will do this patient also.
According to me, we should proceed with operation because this vascularized septum and the location of the cystic mass is in the uncinate process near to the portal vein. So in these conditions, we should followed by surgery.
Which kind of surgery?
For this patient, minimally invasive pancreatectomy is also nice.
Total pancreatectomy?
No, not total. Because the dilatation of the main pancreatic duct is due to the obstruction in the head of the pancreas. So I'll proceed to pancreatectomy.
And I agree. The frozen section is important. This patient's
of course. We will take some comments from the audience. Another decisions.
I think before the operation, we should also discuss with the patient about the possible total pancreatectomy. It looks a little bit, but the atrophy is very significant. This is the first choice is pancreatic heterosection, of course, but there's always a chance in the operation. Sometimes you decide, also because of the frozen section.
Please go ahead.
Okay, thank you, professors. In this case, gastroenterologists decided to proceed with use and FNA. A 35 millimeter septated cystic lesion communicating with the pancreatic duct was observed, and cyst fluid analyzes low glucose, amylase, and CEA levels. And histological evaluation was reported as atypical histology. However, only a small number of atypical cells were observed. At this stage, how would you interpret these findings? Would these results change your management approach?
Whose is this suggestion? Gastroenterologist?
Yes.
Okay, please.
It is completely unnecessary. Completely.
So, any question or comment from the audience? So we have a fluid analysis showing that the glucose level is really very low. CAI a little bit high, but we have atypic cytology. So would you now go directly to surgery or somebody that has the opposite side?
According to me, we have enough indications for surgery before this
More than enough.
endoscopic ultrasound.
I think more than enough.
Okay. The patient underwent a Whipple procedure. Frozen section examination showed no pathological findings at the surgical margins. Final pathology was interpreted as mixed type IPMN with the focal areas of high-grade dysplasia. Low-grade dysplasia was also noted to extend to surgical margins. In this patient, what would your postoperative surveillance protocol be? Would you follow the patient every 6 months, or would you prefer annual follow-up, or with which modalities?
Okay, please.
We should follow this patient every 6 months, at least 3 years, because it will be skip lesions, the rest pancreas, and we should to follow.
Anybody else? Please.
Okay, we have some messages. Incidental pancreatic findings on non-abdominal imaging may be clinically important. A main pancreatic duct dilatation is one of a key driver of risk stratification, and ductal communication is a major diagnostic clue. Atypical or non-diagnostic cytology should not override high-risk imaging features. We will now move on to our third case. Our third case is a 72-year-old male patient who was referred to our center because of a suspicious pancreatic mass detected on CT performed for non-specific abdominal pain. His laboratory was normal. On MRI, the main pancreatic duct was 3 millimeters. 2 cystic lesions were identified, and EUS and FNA was performed. A 3 centimeters multicystic lesion was identified. The lesion had normal nodularity and Musin test positive. Okay, we can see radiological image.
Okay, so this image is going back to 2017. The FATSat T2 images. Directly in the tail, we see a cystic lesion. We see other millimetric cystic lesions, and in the junction of the head and neck, we see another one. I don't know which one they.
I don't know.
Oh, let's go. Say it again. Just you move on. I'll change it. Can you switch to the other screen, please? Oh, no. It's annotation.
Patient data
Can you switch to the other screen so they don't see? Açmadı şey.
Chara, go ahead, please.
Yani
You want to tell something?
Yes, sir.
Okay.
Bizim seçtiğim.
Can I say something?
Okay, you're gonna just trust me because of the confidentiality of the patient. We don't want to show it, obviously. So we have in the distal part, we have a cystic lesion around 1.5 centimeters. We have multiple millimetric cysts consistent with side branch lesions and one around one in the junction of the head and neck. Again, cystic. None of them are enhancing. So you continue and then don't switch to us. I'll just hold. Okay. I'm closing patient.
Okay.
I don't know why this happened.
The team decided to follow the patients with surveillance. The patients was followed for 2 years. During follow-up, MRI showed no changes in the existing lesions and no new pathological findings. At this stage, would you discontinue surveillance or would you modify the follow-up interval? Every 6 months, we have MRI.
From audience, somebody? Mustafa.
Patient has any complaining, any symptoms?
No.
Maybe, yeah, the tumor looks like the similar. There is no any mural nodules. And maybe 1 year, we can survive, we should survive this patient. 1 year, the MRI. Yeah.
Okay.
I also think that annually surveillance for lifetime is needed for this patient.
Any opposite thought?
I totally agree. I'm not opposite to anything, but it's a very common type of patient nowadays. In the old patients group, it's very common to have such case without any symptoms, and it's becoming a big problem for the hospitals right now. They are sending such patients to the clinics, to the pancreas centers, who have 2 centimeter, 3 centimeter big cysts. I think we have to discuss those.
Okay.
Okay, thank you.
We think, yeah, 1 year follow-up with MRI
Okay.
would be proper for this patient, right? Okay, please.
The patient returned for follow-up 5 years later.
So lost to follow-up?
Yes.
Okay.
But he was coming 5 years later. Professoral'dan 2023 MRI.
It requires a different version of the radiant that currently I have. So I'm trying to anonymize it. I don't know why it's not doing. Nope. Nope.
Okay.
Yeah, it's not really. I don't have the version. It's not really. I'll just show you. Hold on. I'll make something else. Okay.
Okay.
High patient data diye bir yer gördük.
I need another version for it, and I cannot download it right now to
Okay,
analyze.
Chara, please.
Sorry for that.
Okay.
Go ahead. With Can you please repeat
Okay.
the findings just before this? The previous slide, please. Okay.
The patient returned for follow-up 5 years later. MRI revealed a 3 centimeter mass encasing the celiac tract, SMA, and portal vein. And the patient unfortunately passed away 11 months later. We have a message from the sketch. IPMN patients are at risk not only for malignant transformation of the cyst itself, but also for concomitant pancreatic ductal adenocarcinoma.
Okay. I think this is very good example of why we need to strictly follow patients, and we need to explain them why this is so much important for their life, not our life, but their life. So now the availability of MRI is across all countries. In Turkey, with plenty of MRI devices, so it's easy for us to follow up patients this situation. And for example, in my practice, I can tell I operated on 2 patients last year who were in my follow-up schedule, but 1-2 years later, and the other one 3.5 years later underwent surgery. Okay, any other comment or question? Please. Microphone.
Thank you. Professor, if we operate the patient, would be changed any changes? Because 1 year radiologic images wasn't anything, wasn't changes in radiologic images. The patient lost. If you do it, if operated patient, it would be changes in prognosis.
Operate this patient?
Yes, if he would be he'd go to operation, what would be prognosis?
Okay.
Is there any prognosis in your experience?
I mean, if we would operate this,
Yeah.
So patient would alive now, probably. But this doesn't mean that we need to be liberally operate every patient with IPMN, because we know
when he arrived, it was second degree. Yes, this IPMN second degree it was, and in second degree, if a patient was operated, and he would be alive. And after 5 years, how would be?
Would be alive, I believe. But this doesn't mean we need to liberally operate everybody, because we know branch site IPMNs has a malignancy of lifetime malignancy risk of 22%, only 22. This means 78% of patients with IPMN, branch duct IPMN, will never develop malignancy. So it's our task, it's our task to separate people who will develop malignancy resulting from IPMN, and patients who will never develop IPMN. So that's why we are following them, right?
Yeah, I totally agree, because we should not forget that every pancreatic operations has a risk of complications, and from that, of course. So the main important message from this case is that we should regularly follow up the patients with cystic lesions at the branch type IPMN.
Is that okay?
Yes, thank you.
Let's proceed to the next case.
Our last case. This is a 50-year-old female patient who presented to emergency department with progressively worsening abdominal pain and dyspeptic symptoms. On physical examination, she had epigastric tenderness, positive rebound tenderness, and a suspected palpable mass. Her laboratory test was normal. The patient underwent ultrasonography and CT imaging. A cystic lesion measuring 5 centimeters was detected in the pancreatic body. MRI was then performed. On the MRI, again, a 5 centimeter cystic lesion was observed. The lesion, several suspicious nodular components, and appeared to communicate with the pancreatic duct. We can review MRI and CT. Can we?
Switch to So on the upper hand corner, you see this is the first CT image obtained in the ER. Directly we see the atrophied distal part of the pancreas. Sorry. Here you can see in the body around 5 centimeters lobulated cystic mass. But distal to it, you see the atrophied pancreatic tail. It could be some septa here. I would recommend further imaging to this patient, but because she was admitted to ER, we would have asked like whether she had other episodes of epigastric pains, so probably an ongoing multiple pancreatitis episodes. We would have asked that. Again, I see some densities here around the lesion, and mild densities again here. We would not call it directly pseudocyst, according to our imaging. We would have at least recommend further imaging or follow up further imaging with MRI. And then also, you said you had palpable mass?
Yeah.
Okay.
This is wall is contrast enhanced.
It's a little bit thick, but I would not say it's enhancing that much. So the main thing here is wall of necrosis and pseudocysts, but
cyst wall is irregular, right?
yeah, it's not smooth margining, but it's not that much contrast enhancing. Maybe I would have combined it with some ultrasound imaging, so we would have seen also the inside, the inside of the cyst.
I think maybe it is the mucinous neoplasm caused to the pancreatitis and chronic pancreatitis. Maybe this patient indication for EUS.
Yes. This patient has indication for EUS according to me, but prior to it, I will continue with the MRI with DVI. So we'll look for any suspicious malignancy. And after that, we could make endoscopic ultrasound to its transgastric puncture with this cyst.
Thank you. And then they did MRI. So in T2 images, you see the cystic lesion again. This time I see a suspicious of septum here. But mainly I see some nodular. Oh, sorry. Again, we have to trust. Among the T2 images, this time it's again lobulated. I see a suspicious septum here. Again, these are like 5 millimeter thickness. So we would have continued with some thinner slices, but I can be suspicious of a mural nodule here, and also maybe here. I would have wanted to see contrast enhanced images. They didn't open, they didn't work. So we only have the raw MRCP images, sadly. But again, I'm very suspicious of some millimetric mural nodules inside it. So it's not that easy to say this this is a just plain complication of chronic pancreatitis. And we would have recommended this time biopsy. Okay. Then we have a CT 1 month later, I think. Hold on.
It's very important that we do the next examination 1 month later, because the patient was admitted with acute symptoms. It's not suitable for elective surgery at this time.
But I want to
continue.
but I want to highlight that the amylase level is very low.
It
In
it is also there is also amylase level high in IPMN, right?
Yeah, but low is really double question mark.
Okay, I can show you use an FNA.
Why analyzes fluid analyze CA99 level? Çağrı.
We have a problem with gastroenterologist.
This time the CT images. For me, again, we don't have the because we didn't have the enhanced images for the MRI, but I can go back to me. Go back. Thank you. I can see some suspicious enhancement here, but the main thing is the irregularity around with the vessels. This can also be because of pancreatitis, yes. But now we are following it up. We would expect at least some regression around the densities. So we are still suspicious for this. We would definitely recommend biopsy for this.
Okay, sunumu alabilir miyim?
Slide.
Slide sunum presentation. Okay. Use and FNA was performed and there was a 6 centimeter cystic lesion and was reported as a pancreatic pseudocyst. Cyst fluid analyzes low glucose amylase levels and high CA and CA99 levels.
Amilaz olur mu?
On pathological examination, it was stated that a distinction between benign histology and low-grade dysplasia could not be made. Based on additional findings from MRI, US, and pathological examination, how would you approach this case now?
Okay, anybody?
Yeah, I think no need rep biopsy. I thought there should be surgery first.
But portal vein invasion, maybe we have a portal vein invasion here.
We can resect the portal vein. Huh? We can resect. Maybe this is the miscellaneous cyst plus maybe carcinoma. We don't know it. No need more biopsy.
Okay. Okay.
And also there is a point here, during the endoscopic ultrasound, they are not reporting mural nodules. Yeah? This is also interesting. I think it shows also the necessity of this.
That's very important point. Okay.
But it's obvious that this cyst must be resected. It is a
you know, and this is, I think, fine needle aspiration cytology, right? Not the biopsy.
Actually, after the MRI finding, also EUS indication, there was no. After MRI finding, because you said that there's some nodules, and yeah.
Yeah, we don't have the contrast and enhanced images, but it's obvious that they are mural nodules. I can just.
I totally agree with you, because if we chasing new biopsy, we will lose time for this patient. So
and also
we'll proceed with the operation.
Yes, but any you know, somehow if patient underwent endoscopic ultrasound before referral to us, it should report whether the biopsy was taken from the mural nodule or in the cyst on the fluid examination. It's very much important, and mural nodule should be biopsied with another aspiration cytology, but fine needle aspiration biopsy. So, okay. Çağrı?
After this point, the patient presented to another center and a repeat CT scan was performed, same lesions. And use was then repeated and there was 6 centimeters cyst, the main pancreatite was identified in the pancreatic body. In addition, a 9mm transmural nodule was detected. The mucin test was positive. Overall, the findings were interpreted as suggestive of IPMN or mucinous cystic neoplasm. Biochemical analysis was low glucose and amylase levels and high CEA levels. Pathological examination was interpreted as a low-grade pancreatic neoplasm favoring mucinous cystic neoplasm or IPMN. However, the pathologist state that malignancy or high-grade dysplasia could not be excluded because the samples were hypocellular. Based on the last findings, the repeat use findings, what would be your management and approach? Is there anything changed?
This is a repeated mistake here. Repeatedly mistakes, because doesn't patient have an indication to undergo endoscopic ultrasound? Still, they took cytology, not the biopsy. I mean, please.
Yeah, if the biopsy also negative is, she should be rejected.
Not will change.
She will be operated. And moreover, this is not only unnecessary, this is also dangerous. Some surgeons or gastroenterologists trying to make it again and again, cyst fluid analysis or cytology, and this is negative. It is also right now difficult to explain to the patient the necessity of the operation. Why is this negative? But she has perhaps cancer. We all know it.
Actually,
that's why it should be avoided to perform. If the operation is indicated,
yes.
I think this is not only unnecessary, this is also dangerous for the patient because of the time loss. And also
risk of bleeding.
It's mind-blowing right now
yes.
for the patient and the family. Yeah.
Okay.
Okay. After 3 months, her first admission, and the team decided to proceed with surgery in this patient. After laparotomy, exploration revealed multiple implants on the peritoneal surface and in the colonic mesentery. Frozen section examination of these lesions was metastatic adenocarcinoma. The patient was therefore considered to have peritoneal carcinomatosis, and creative resection was abundant, and the patient was referred to oncology.
Okay. Is there anybody who would start with the laparoscopy? This case, laparoscopy first.
Maybe the main important message from this case is that we lose a lot of time to try to diagnose something that was obvious from the first sight. So in these cases, we should proceed to the operation immediately. Are there any comments from the audience?
Okay. Okay. Okay. Any question or comment from the audience now?
Okay. If no, thank you.
Okay. We have some gifts from Dr. Tasheyev to our guests. Please, let's take to them.
Thank you for your participation and active participation and wonderful presentation. And thank you for comments, very interesting comments and presentation. And small gift from Uzbekistan.
Okay, we are closing our session. Somebody else? Okay.
Yeah, Ahmed. Selamlar. Thank you. Thank you very much for your participation and very interesting presentations, comments. Thank you very much.
Okay. We thank all our audience for the contribution, and we're closing our session. The next session will start at 11:30. 11:30.
Dear guests and dear participants, we are starting now last session of our Congress. We have some changes. First, Professor Veysel Umman.
Hello, everyone. Welcome to the last session of this beautiful Congress. I would like to thank the organizing committee and all participants. My topic will be portal vein embolization and liver venous deprivation, the indications, techniques, outcomes, and the gray zones in between. So I would like to start with a gray zone case. If there was a patient, 62 years old man, with sigmoid primary tumor and 6 bilobar liver metastasis, and the largest 7-centimeter tumor in segment 8. And this patient received FOLFOX and bevacizumab therapy, and there was some shrinkage, but the tumor did not completely disappear, and you had to do extended right hepatectomy and left wedge resection. But the CT volumetry says that the future liver remnant is around 28%. What would you do at this point? So this is a gray zone patient. Would you directly operate because it's 28%? Would you listen to your radiologist and do a portal vein embolization? Or would you listen to your interventional radiologist and do a liver venous deprivation? Or would you listen to your oncologist and do a 6 more weeks of chemo? It's around 1.5 centimeter in the left lobe. So it's going to be a wedge resection. So to complicate the question even a little bit more, what would happen if the first time the tumor was around, the future liver remnant was around 22% in CT volumetry, and you preferred to do portal venous embolization, and now after 4th week, it's now 28%. Would you operate? Or would you prefer to do one more waiting session? So at 6 weeks, now it's 29%. So these patients are very hard to decide. And in this talk, I will try to understand, explain the major challenges, which are, is 22% future liver remnant truly a real functional sign? Did chemotherapy cause a liver injury and affect the volumetry? Should we have chosen liver venous deprivation instead of portal vein embolization? Or 29 hypertrophy is enough? Or a 6-week period may cause tumor progression, and should we wait for it? So in this presentation, I'll try to answer these topics by 5 questions. Why, when, what, which, and the workflow. Why do we need to use liver hypertrophy procedures? When exactly should we use these methods? What are the differences between these methods? And which one is better for which specific indication? And finally, the workflow of
how to proceed in these procedures. So why do we grow the liver? We grow the liver because most of the advanced tumors require removal of more than 4 segments. Once you remove more than 4 segments, it's a major hepatectomy, and post-hepatectomy liver failure remains a feared complication around 15%. And future liver remnant is the only safety lever, and screening number up to 30% usually is very important, and it can turn, this hypertrophy can turn an unresectable lesion to a resectable lesion. And portal venous embolization is standard for almost 3 decades now, but up to 20% of these patients drop out before surgery, either due to insufficient growth or tumor progression. And then we have liver venous deprivation, which allows us a faster future liver remnant growth and also narrows the dropout period. To whom should we do these methods? A normal liver, usually it's told that 20% is enough, but nobody usually leaves 20% of a remnant liver. A chemotherapy-induced and injured liver should be target more than 30% of remnant liver. If cirrhotic, fibrotic liver is present, then more than 40% should be aimed. And in borderline cases, we should always keep in mind that the numbers usually don't tell us the whole picture. Volume does not equate function. 28 future liver remnants in a normal, chemotherapy injured, or cirrhotic liver, those are not the same. So 28% future liver remnant does not equal to same thing in every patient. When we look at the terminology, there can be some differences. Some studies call it LVD, some call it dual vein embolization, some call it RASPE, radiological simultaneous portohepatic embolization, some call it bi-embolization, but they all refer to the same thing. If we take a look at the evolution of the hypertrophy strategies, it all started with Makuche, 1990s, the portal vein embolization. And then slowly liver venous deprivation was founded by Gui, and he also came up with extended liver venous deprivation, which involves occlusion of the middle hepatic vein as well. And towards 2020s, more case reports and cohort studies started to be published. And around the last 2 years, there are still ongoing important randomized controlled studies. And this is still answer of this topic, which one is better, is not quite scientifically set. There are technical details, so it's shorter in portal venous embolization, and you only block the ipsilateral transhepatic side, but in liver venous deprivation, you can, in addition to the ipsilateral hepatic vein, you can also block the middle hepatic vein, and the procedure time is longer. The details of portal venous embolization: you start with a portal branch, which is occluded, and embolize the lobe that's targeted. And then there's apoptosis and also atrophy of these blocked liver, and compensatory growth signals growth of the future liver remnant. And finally, this hypertrophy takes around 4 to 6 weeks. But there are very important details. Then there are studies on these details as well. One of them is the method of blockage. The embolic agents differ completely, and there's been a randomized control study called BEST FLR, and it's been shown that the best method to close is N-butyl cyanoacrylate, and otherwise an incomplete occlusion ends up with failure of this method. When we look at the success of this portal vein embolization, we see that it's quite long that it's been used. So there's decades of evidence that it's safe. It enables resection up to 80%, which is also meaning that around 20% fails to reach adequate FLR before the resection time. And there are 2 important factors. 1, the tumor progression, since it takes longer time, and 2, there is an effect called hepatic arterial buffer response, which might feed the tumor. What happens when you occlude the portal vein? The portal washout is continued with arterial vasodilation. This arterial vasodilation is a compensatory method, and it creates an arterial steal syndrome that liver tries to compensate for the tumor-bearing, tumor-included lobe. this is a clinical concern, and it's not quite understood how this affects the oncological outcome. So the liver venous rationale is rising from this logic. It induces sinusoidal congestion, blocking both the outflow as well, and the result is a more intense atrophic stimulus to the resection site. For the liver venous deprivation, here we see that the future liver remnant rose from 34% to around 50% in a short amount of time, in 3 weeks. So there is dual occlusion advantage as well as the less hepatic artery buffer response. In addition, in certain selected cases, there can be extended liver venous deprivation. This includes the occlusion with this unplastered flux of both right hepatic vein and middle hepatic vein, which even increases further growth. So when we look at this growth and when we try to measure the growth, there's a very important metric that we have to pay attention to, and it's KGR. The first week tells us more about the kinetic growth rate than the volume itself, because a rapidly growing 24% future liver remnant is more safe to operate on than a liver that's 28%, but it's slow to grow. So hypertrophy kinetics is very important here, and we usually pay attention to KGR here as well. Therefore, how the liver grow is also important rather than just how much the liver grows. If you look at here, we see that in portal venous studies, usually patients drop out without even being operated, either due to tumor progression or insufficient hypertrophy. Even when they get laparotomies, they get encountered with more tumor progression. And here, at that point, we come up with the idea of the functional imaging. So we need scintigraphy or contrast-enhanced MRI or other methods to differentiate not just the volume itself, but how much the liver actually is functioning. So when we look at the DRAGON study, which is, there are second phases of the study that are still ongoing, but the first one, it gives us quite a summary of the comparison between two methods. We see that higher FLR hypertrophy, higher kinetic growth rate is visible and meaningful with LVD, and a lower resection to failure and higher resection rates are seen compared to portal venous embolization. And while having these advantages, there is no significant difference in post-hepatic liver failure, and there are no significant differences in complications on mortality. So living venous deprivation achieves better hypertrophy and resectability than portal venous embolization. But volumetry, as I told, is not enough. So certain high-risk phenotypes are critical, such as a patient with diabetes, cirrhosis, cholestasis, peripheral cholangiocyte carcinoma, or a long neoadjuvant chemotherapy, steatohepatitis, or patient with low KGR, less than 2% per week, are important risk factors that we have to pay attention. And we should always keep in mind that volume might look fine. It might look that a patient at 58-year-old with 6 centimeters HCC has a good volume, but the function in ICG reuptake or LIMAX test might be poor. So functional future liver remnant is more important than just the volumetry itself. Okay, then what type of method should we choose in terms of the etiology of the patient? Does it differ? Yes, there are recommendations on these as well. Usually it is advised that for colorectal liver metastases with chemotherapy injured livers, portal venous embolization should be tried first, and LVD should be reserved if the volume is extremely low, and the injured parenchyma regeneration should be kept in mind. HCC for non-cirrhotic patients, again, portal venous embolization. If there is cirrhosis, cautious liver venous deprivation should be tried. And for classic tumors, PV is standard, but again, selectively LVD can be used. And again, intrahepatic cholangiocellular carcinoma should be individualized, but LVD sounds reasonable due to very little time and quick progression of the disease. And in certain patients, embolization is not recommended when there's biliary sepsis and risk of abscess, and the tumor control is not there. It's not advised. So as I told, it's important that the problem is not just about the volume, but also the tumor biology. When we say which one is better, certainly there is greater and faster volume with LVD. That's certain. Higher resection rates with lower hepatic failures, that's also probable. But what's unproven is if there's an overall survival benefit and there are no randomized studies. So patients who are extremely in worst conditions are sent to LVD compared to portal venous embolization. So there's not quite randomized studies, and this creates an oncological window. What I mean by oncological window is anytime you perform embolization, the hypertrophy window is also your tumor progression window. And at that time, you can lose the patient due to progression. Now, a couple slides about the current evidence of this topic. The evidence, as I showed you, started with GUI, and then the couple comparative cohorts came, and finally, now there are around 4 meta-analyses and the ongoing trials. Couple quick remarks about those studies. One is by Dr. Bozkurt, meta-analysis. It shows that in 23 studies, around 1,500 patients, LVD gives best balance, strong growth with lowest risk. Another study, again looking at 10 studies with 500 patients, shows that more patients reach surgery with LVD and liver grew faster and with same safety. Another study of meta-analysis of 700 patients shows that bigger remnant is possible with better growth rate. And another meta-analysis again shows that it's faster and reaches a bigger liver. So all 4 meta-analysis shows that LVD can be preferable. And these are the latest evidence that are ongoing, especially dragon studies that we are, and hyperlive studies that are investigating these comparisons. But it should be kept in mind that when we are comparing this, there is a selection bias because it's, as I told, that chosen for the hardest cases. The reporting is not quite homogeneous. The technique has some weaknesses, such as I told you, the way of embolization creates a heterogeneity. Not every embolic agent closes the portal vein completely, and it creates a shallow cast, and that should also be checked. To overcome that, there is a new standardization of cursus standards to how to report these comparisons, and a unified framework of how to embolize, how to do the pre-procedure workup. The technical standards of how to use embolic agents have been published just to have a good comparison between studies. Last couple slides. So how do we do the workflow? First, we define the tumor, what type of tumor it is, and the liver parenchyma. If it's normal, chemotherapy injured, or cholestatic, then we decide about the future liver remnant as well as the function of the liver. We calculate the FLR and flag the risk patients. Also, we do scintigraphy or MRI to see if the function is also there. Finally, we decide on the hypertrophy strategy. Either we don't need it at all, it's adequate, or it's borderline according to the etiology. If there's time and the biology is favorable, we can do portal venous embolization. But if there is low volume and the need for hypertrophy is faster, then we have to choose living venous deprivation, similar in aggressive biology for extended as well. Finally, we do step 4 re-evaluation at around 2 to 3 weeks to see both the volume and function. If it is adequate, we can proceed to resection. Inadequate, either you can do a rescue procedure or you start systemic therapy. And if there's progression, this patient should go to oncology. The future will tell us about the exact randomized comparison, as well as which patient responds to these therapies and what are the oncological outcomes. These are the informations that we do not have yet, and we should keep in mind. Our final summary points is the patient is limited not just by remnant liver, but also tumor biology. We should not just trust the FLR as a number, but also we have to check the function. We have to match the tools to the patient. what's the least aggressive strategy that wins against a clog of the tumor. Portal venous embolization is simpler, cheaper, available, there is lower radiation, but also there is the time constraint, and liver venous deprivation is growing more and there's less dropout. So these should be kept in mind, and volume is not the endpoint. Completed resection without hepatic failure is the endpoint. Thank you for listening.
Thank you, Professor, for your nice presentation. Are there any comments or questions? Okay, please, sir.
Thank you, Doctor, in your very nice and important presentation. And I would like to ask you a question. What about in your case, and how many patients you manipulated this way? And after that, what's the complication as a result in your practice? Thank you.
Thank you. In terms of the complication of the technique, there are not high complication rates reported, and we did not experience severe complications such as bleeding. This is safer procedure compared to such as TIPS procedure, less invasive because there is just embolization and the access is from a peripheral vascular area. So the complication just related to the procedure is not our main concern, but the main concern is the tumor progression and the time to operate. Therefore, we try to choose according to the biology of the tumor and the remnant volume of the liver. If there is less volume and the tumor is aggressive, we tend to choose liver venous deprivation. But if we have time and the patient is tolerant, there are more cases that we prefer just portal venous embolization.
Okay, thank you. As you know, Professor Eldam is also with us. As you know, she's an interventional radiologist, and she may also have some comments to add.
Why don't you combine your PVE or bivenous embolization with TACE and TARE? It's because it's about tumor biology. The venous embolization, PV, it's all about future liver remnants, but tumor biology is always there. It doesn't matter whether it's HCC or colorectal. You can always combine it with them. In our center, it's regular. When we do PV or venous, 1 week later we combine it with either Y90 or TACE, because hepatic buffer, although it decreases, it is there.
This is excellent point. I was wondering if anybody would ask, but of course, an interventional radiologist asked this question. There are reports now. It's highly preferred that TACE should be combined with liver venous deprivation. As you said, the still hepatic arterial buffer and the collateral feeding of the tumor-bearing lobe is still present. Therefore, now there are reports of TACE being included in the LVD. But due to short time of the presentation, I didn't want to go deeper into other reports and wanted to mainly compare portal venous embolization and LVD. But nowadays, the publications are turning more towards using TACE as a combination. You're right about that.
Maybe one suggestion. Doing venous embolization it should be. I'm a big fan, by the way, of venous embolization. It's when you compare it to ALPS, because you don't open up the patients, so it's going to be your second operation. So it's regarding to those complications, it's better.
ALPS comparison is another important point, but Professor Can is going to talk about it, so I didn't want to get into that part either. I wanted to specifically compare portal venous embolization and liver venous deprivation, but you're right, it can be a rescue treatment, a very limited selection of patients, but I think Professor Can will give further detail on that. Thank you.
Okay, thank you, Professor Roman. We will now continue the session with Professor Cihan Agalar. Professor will talk to us about hybrid approach. The floor is yours, Professor.
Dear fellows and colleagues, I'm glad to be here, and we reach our last day of our Congress, and I'm very happy with in last session with this full hall. Thank you for everyone. Today I will discuss a hybrid approach for future liver remnant optimization. Our main focus will be colorectal liver metastasis. This is my presentation plan. I will firstly briefly review the history of hypertrophy techniques. Then I will discuss the physiology of liver regeneration and try to explain why volume alone is not enough. After that, I will present the main hybrid approach and future expectations like stem cell augmentation. Finally, I will try to discuss failure and rescue options and present a practical decision algorithm for patients. Dr. Veysel also commented that post-hepatectomy liver failure remains one of the most important causes of morbidity and mortality after major liver resection. The reported incidence ranges from 0.7% to 35%. Portal vein ligation and portal vein embolization are established and relatively safe methods. ALPS provides much faster hypertrophy, but we should notice that it's more invasive. Portal vein embolization plus hepatic vein embolization, Dr. Veysel also teach us, called venous embolization or liver venous deprivation, may provide stronger hypertrophy without surgical partition. Hybrid approaches try to combine the advantages of different methods while reducing their limitations. We can say that the future of future liver remnant optimization is not choosing one technique, but selecting the right combination for the right patient. This is important at the right time. The history begins portal vein ligation, and portal vein embolization was introduced by Makuchi group. And around 1980, it later became a standard method before major hepatectomy. In 2007, ALPS was first performed by Schlitt in Regensburg. And from approximately 2016, venous embolization is much gaining popularity. The high complication rates of early classical ALPS encourage surgeons to develop less invasive variants. These are some variants: partial ALPS, mini ALPS, hybrid ALPS, tourniquet ALPS, and radiofrequency assisted ALPS. Before discussing hybrid strategies, we need to understand the physiology of future liver remnant growth. When the portal branches to the tumor-bearing liver are occluded, portal blood flow is redirected to future liver remnants. This increases portal flow, shear stress, and portal pressure in the future liver remnants. These chains activate the Kupffer cells, sinusoidal epithelial cells, and hepatocytes. They release cytokines and growth factors, includes interleukin-6, TNF-alpha, hepatocyte growth factor, epithelial growth factor, vascular epithelial growth factor, and nitric oxide. The early response includes hepatocyte hypertrophy. This followed by hyperplasia. Later, before choosing strategy, we should assess 4 elements: volume, function, growth kinetics, and the remnant would be tumor-free. We should ask, is the growing fast enough, functioning well enough, and free of tumor? In this slide, I would like to define a hybrid approach. A hybrid approach is not name of one single procedure. A better definition is planned combination and different augmentation and achieve to tumor-free resectability in colorectal liver metastasis. The first one is portal flow occlusion. These are venous embolism. These include venous embolization. Outflow deprivation includes Dr. Veysel comment us about this issue. Third group is parenchymal injury, includes ALPS. Dr. Fatih Can talks about us. about the ALPS, and I want to speak about the partial ALPS and other variants and tumor control factors and biologic augmentation. We can say that hybrid strategy is not about choosing most aggressive method, selective escalation, matching the intensity of future liver augmentation, tumor biology, liver quantity, and the correct time. This table shows that ALPS is no longer a single standardized operation. The original technique was classic ALPS. Over time, several modifications were developed to reduce surgical trauma, preserve liver tissue, and adapt the procedure of different anatomic and oncologic situations. In the following slides, I will focus on most clinically relevant modifications for colorectal liver metastasis, partial ALPS, mini ALPS, hybrid ALPS, tourniquet ALPS, and radiofrequency-assisted ALPS. First one, the partial ALPS. The main strength of classic ALPS is very rapid future liver remnant hypertrophy. However, complete parenchymal transection during the first stage may increase the risk of bile leak, infected collections, segment 4 ischemia, sepsis, and post-hepatectomy liver failure. Partial ALPS was developed to reduce this problem. The basic idea is simple: preserving segment 3 venous flow, and if possible, preserve the middle hepatic vein. Complete transection may not always be necessary for enough future liver remnant hypertrophy. A limited degree of parenchymal separation together with portal flow redirection may be enough in much patients. In practice, partial ALPS usually means 50 to 80% parenchymal transection. The aim is reduce the intrahepatic portal collaterals and stimulate the future liver remnant group while avoiding full trauma and for complete liver splitting. In bilobar disease with a small future liver remnant, if rapid hypertrophy is needed but classic ALPS seems to be aggressive, partial ALPS may be a more balanced option for this patient. But there are some limitations. If the tumor is very close to future liver remnant and there is a risk of invasion between this stage, partial split may not be enough. In this situation, a more complete transection may be required. We can address the partial ALPS, safety version of classical ALPS. The second modification is mini ALPS. The concept of mini ALPS is to invert the classic ALPS paradigm. In classic ALPS, stage 1 is quite aggressive. It includes portal vein ligation, wide parenchymal transection, and sometimes future liver remnant clearance. Mini ALPS tries to make stage 1 as small as possible. Technically, mini ALPS combines partial parenchymal transection with intraoperative portal vein embolization. So portal vein ligation is replaced by embolization, and liver splitting is limited rather than complete transection. This is especially relevant for colorectal cancer metastasis. In bilobar colorectal cancer metastasis, we can often combine future liver remnant clearances with limited split and portal vein embolization. This advantage of mini ALPS, stage 1 is smaller, hilar manipulation may be reduced, adhesions may be less severe, and stage 2 may be performed under safer conditions. But these have some limitations only. These needs careful multidisciplinary planning and experience for its intraoperative embolization. Our third technique is hybrid ALPS. The main change is the replacement of the portal vein ligation by portal vein embolization. In classical ALPS, the right portal vein surgically ligated during stage 1. In hybrid ALPS, portal vein of control is achieved by interventional radiology. The goal is reduce hilar manipulation and avoid excessive handling of the tumor-bearing liver. The avoid voltage concept by Lee and colleagues also important here. In large tumors or tumor close to hilum, avoiding major manipulation during the stage 1 may be oncologically attractive. Therefore, hybrid ALPS is not only a regenerative strategy, it also has been an oncologic rationale. In colorectal cancer liver metastasis, hybrid ALPS may be considered in some patients. The limitation is complexity. Surgery and intervention radiology must be well coordinated. Also, strong comparative data showing clear superiority over classic ALPS are still limited. Hybrid ALPS keeps the rapid hypertrophy concept of ALPS, but shifts portal flow control from surgical ligation to embolization to order the reduced stage 1 manipulation. Tourniquet, this is tourniquet ALPS, also called ALTPS. During stage 1, a tourniquet is placed along the planned future transection line, and portal flow also changed to other side. The tourniquet creates a mechanical partition effect and may produce an avascular growth before stage 2. The aim of to provide the hypertrophy of stimulus of ALPS while reducing the raw transfection surface. Potential advances include shorter and less invasive first stage and possibly lower biliary and septic morbidity. However, the evidence is mainly retrospective. The technique is not fully standardized, and the partition effect may vary between patients. For colorectal cancer metastasis, ALTPS can be suitable in selected patients in whom classic ALPS seem to be too aggressive, but portal venous embolization may not be suitable for slow growth. The fourth modification is radioactive ALPS or RALPS. The aim is replace complete surgical transection with a virtual partition created by radiofrequency ablation with this device. The zone is created with this device. The zone is biologically mimics the effects of parenchymal splitting. In the review of Medal of Oncologists, RALPS is described as the ALPS variant. The most important clinical evidence is Rebirth randomized trial by Jiao and colleagues. This trial combines compared RALPS with portal vein embolization. The mean increases in future liver remnant volume was 80% in the RALPS group and 18% in the portal vein embolization group. Final resection was achieved in 92% of patients after RALPS and 66% after portal vein embolization. These data suggest that RALPS can induce rapid and strong future liver remnant hypertrophy without complete surgical transection. However, we should be careful. The radiofrequency line, its depth and its relation to vascular structures and tumor distribution must be carefully planned. In colorectal cancer metastasis, radioactive assisted ALPS may be considered when rapid hypertrophy is needed. Classic ALPS seems too traumatic, and portal venous embolization may be too slow or insufficient. Radiation lobectomy used with yttrium-90 microspheres delivered into arterial supply to the tumor-bearing lobe. The treated lobe may develop local tumor control and gradual atrophy. At the same time, untreated contralateral liver may develop for compensatory hypertrophy. TARE should not seen only as a hypertrophy technique. It's a liver-directed treatment that can provide local treatment of tumor lobe, while some increasing in the opposite lobe. The major limitation of this technique is timing. Hypertrophy after TARE is usually slower than after portal vein embolization, liver venous deprivation, or ALPS. Dr. Gonca should comment us. These techniques and TACE can be combined with other techniques, and this gaining some importance. Thermal ablation can be used clearing lesions in the future liver remnants, especially, or this is important, smaller than the 3 centimeters. The aim is obtain tumor-free future liver remnants while preserving as much as functional liver to the tissue as possible. In future, liver remnant hypertrophy also requires portal vein embolization may be performed either simultaneously or sequentially. In this setting, ablation treats the future liver remnant lesions while portal venous embolization induces hypertrophy. The literature also describes portal vein embolization combined with RFA or microwave ablation to create a virtual partition effect, but evidence is small. The liver venous deprivation became gaining importance, but there is no enough evidence to publish. Portal vein embolization with stem cell augmentation, or the name PVESA, belongs to the category of biologic augmentation. The basic idea is simple: keep the safety of portal vein embolization, but add regenerative cellular signals to improve future liver remnant growth. This is theoretically important. Many colorectal cancer metastasis patients receive long courses of chemotherapy. They have sinusoidal injury, steatohepatitis, sarcopenia, or reduced functional reserve. Stem cells may support future liver remnant growth through several mechanisms. Paracrine signals such as epithelial growth factor, vascular epithelial growth factor, and something. However, we should keep in mind that this is a not routine standard. This is just augmentation technique now. Even after a technically successful procedure, the treatment plan may fail. The first failure point is insufficient hypertrophy or low kinetic growth rate. The second is tumor progressions during the waiting period, which may lead to surgical dropout. The third, detection of new lesions. The third is detection of new lesions, particularly in the future liver remnants or intraoperative finding in intraoperative ultrasound. The fourth one is mismatch between volume and function. The future liver remnant may appear large enough on CT, but functional reserve may still be inadequate. After every future liver augmentation procedure, we should therefore reassess the future liver remnants volume, function, kinetic growth rate, liver quality, tumor status, and possibility to complete future liver remnant clearance. The term rescue liver venous deprivation is not always used directly in the literature, but the concept clearly exists. In patients with insufficient future liver remnant hypertrophy after portal venous embolization, ipsilateral hepatic vein embolization can be added. Rescue liver venous deprivation may be considered when the portal vein embolization has produced insufficient growth, the disease remains controlled, and hepatic venous anatomy is suitable. It may be less invasive rescue option before rescue ALPS. Rescue ALPS is another option when the volume is insufficient. We can use rescue ALPS. There are some articles in the literature. Sperrelt and College reported 11 patients, and ALPS registry group reported 20 salvage ALPS patients. But we need to highlight this. Failed portal venous embolization does not automatically convert to the rescue ALPS. Disease status, patient fitness, future liver remnant function, and the expected oncological benefits must be first reassessed. It will be good. This will be done in the multidisciplinary tumor board meetings. The decision when we this is my last two slides. This decision should begin with assessing 6 variables: the future liver remnant volume, future liver remnant function, kinetic growth rate, quality of the liver. Can the future liver remnant be completely cleared of tumor? And how much time is available before surgery? If time is available, dropout risk is low, and expected hypertrophy is not much. Portal vein embolization or portal vein ligation is the reasonable first-line option. is the future liver remnant is small or needing, we need strong hypertrophy, liver venous deprivation may be selected, or if the future liver remnant is not clear, ALPS can be selected in this patient. If we performed portal vein embolization and we failed, rescue ALPS or rescue liver venous deprivation is an option. If your patient is not suitable for the classic algorithm, you need to choose hybrid approaches. If we know lesions in the future liver remnants below than 3 centimeters or less, thermal ablation or limited wedge resection can be combined with portal vein embolization or ligation is a good option. Is portal vein embolization is too slow, or we need much more future liver remnants? Liver venous deprivation or ALPS can be chosen. If hypertrophy after insufficient portal venous embolization, we need rescue. We can use rescue techniques. If rapid growth is needed, but complete split is too traumatic, we try to use ALPS modifications. Is the dominant tumor bearing lobe requires local treatment and surgery is not urgent, TARE may be considered in the poor quality. TARE can also be used with portal vein embolization or maybe in some patients, in very, very small patients with liver venous deprivation. In the future, poor quality of chemotherapy exposed liver, PIVESA, the biologically attractive agents can be used, but this is investigational today. Thank you for your patience.
Thank you, Professor. Are there any questions or comments? Okay, thank you, Professor.
Yeah, Kovaka. Next presentation is ALPS procedure, indication and risk. Mehmet Fatih Khan from Turkey, please.
Dear chairpersons, dear colleagues, now I want to summarize the current literature with our experience with the associating liver partition and portal vein ligation for stage hepatectomy. As my previous colleagues, Veysel Umman and Cihan Ağalar mentioned, associating liver partition and portal vein ligation for stage hepatectomy procedure is one of the alternative way to overcome insufficiency problem with the future liver remnant volume. During ALPS procedure, we perform 2 stages. During first stage, we perform liver parenchymal transection plus portal vein ligation. And 1 to 2 weeks later, the second stage is performed and completion hepatectomy is done. As Cihan Ağalar also mentioned, Dr. Schlitt from Germany was the first person to perform the ALPS procedure by chance in 2007 for a case where the future liver remnant was deemed insufficient during surgery. When we look at the geographical distribution of ALPS procedure, we see European countries, China, and some other countries that we can see here. As of 2019, total number of ALPS procedures performed across the world was 1,215. For those who are interested in performing ALPS procedure and entering their data, we have a ALPS registry based in Switzerland. And now the registry has 1,000 and about 300 cases already entered. And many of papers, literature information is given from this registry's knowledge and database. As my colleagues mentioned, I want to just repeat, we have some modification to ALPS. We can, separate into three subtitles of this issue. One, separation techniques, how to separate, how to partition, perform partition of liver parenchyma. The second one, surgical approach, whether it's an open procedure, laparoscopic or robotic. By the way, the first stage may be laparoscopic or robotic, and the second stage may be open, of course. And anatomical modifications, other than classical ALPS, we have reversal ALPS, mesohepatectomy ALPS, and monosegment ALPS. This is an example from our archive. This just was a recent managed patient at our clinic. This was a 60-year-old female patient having type 3A perihilar cholangiocarcinoma, who weighed 67 kilograms. We found there's a 3 centimeter mass in the right lobe of the bile duct. So this was deemed as a perihilar cholangiocarcinoma. And as a first stage, we performed a portal vein embolization, and simultaneously, just only 2 days later, 2 days earlier, laparoscopic hepatotomy partition intervention. After first stage, as you can see here, our volume, as you can see here, our volume significantly increased. There is no problem. This is there was a very small lesion here, which we took during the first stage of surgery and sent to pathology, and that was a benign lesion. And after that, we completed the hepatectomy as a right trisectionectomy. And as you can see here, the follow-up CT images, the left lobe, the left lateral lobe has significantly grown. The most important thing in this issue is safety and efficacy, of course, of this ALPS procedure. So to be able to perform safer this technique, some minimally invasive or partial ALPS procedures are recommended. When we look at this table, we can see that the mortality is better. I mean, this group has lower rate of mortality if ALPS procedure is performed as a minimally invasive technique, and liver hypertrophy is the same in both groups. Okay, now the safety is important, but the liver growth prediction is again the same, an important point for this. This is a multi-center analysis from an international ALPS registry that I mentioned before, based in Switzerland. And we see here that if patient, this is a multivariable analysis of this registry, and we see that if patient received chemotherapy before ALPS procedure, it's a negative factor preventing sufficient liver hypertrophy. Again, if we have any problem, severe complication, Clavien-Dindo 3 or more severe complication after stage 1 of this procedure, again, the hypertrophy is less than expected. So to overcome the complication problems, partial ALPS procedures were recommended. when we look at this slide, partial ALPS procedure has a significantly less mortality rate compared to conventional standard ALPS. And again, the complication rate is a bit less, but there's no statistically significant difference. So in our practice, partial transaction is our standard approach during ALPS procedure. So what does a partial transaction mean in real life? So segment 4 pedicle should be preserved if this pedicle located deep in the liver. But it's superficial, we can ligate it and cut it. Extra-Glisonian approach should be adopted. This means we need to leave some parenchyma on hilar plate. We don't need to touch. Actually, we need to avoid touching hilar plate because this brings risk for bile leak. Also, preservation of middle hepatic vein is an important point to avoid complications. There have been some scoring systems to evaluate these risks in patients with undergoing ALPS procedure. This is one of them, and the Capra score. And this in this series, the overall mortality was 14%. 14%. Okay. So if patient experience any biliary complications, bile leak, and followed by infection, the mortality is almost twice. Again, from this paper, if we perform classical ALPS, the mortality is about 20%. But if we adopt partial ALPS, mortality significantly dropped to 1/4 of this series. So if we have a severe complication after stage 1, as I mentioned during the previous paper, the mortality is significantly unacceptably high. So risk of mortality high if Capra score is over than 4.7%. And the variables are age, body surface area, primary liver tumor, existence of primary liver tumor, severe cardiovascular disease, renal disease, and performing classical ALPS. This is another risk assessment score where we can easily use laboratory analysis results. This is a AS2 platelet ratio index and albumin bilirubin index. It's a kind of calculation, but we can easily calculate this. And after interstage normalization of the score, we should proceed with the second stage. Otherwise, it's really risky. So in my clinical practice, this is very important and alarm findings. I don't want to proceed with the second stage if within the first 10 to 15 days, I experience one of the following. Targeted volume couldn't be reached. Targeted functional capacity couldn't be reached. If we have a major bile leak, if we have a high level of total bilirubin, ISGLS level 2 or 3 means very high liver insufficiency or abscess clinical relevant infection. In these situations, this patient shouldn't proceed with second stage. So I want to complete my talk with demonstrating our experience. To date, we have performed 24 ALPS procedure. Interstage interval was 6 to 13 days, median 9 days. So we we have only one patient that couldn't be moved to second stage in 15 days, who had a colorectal cancer liver metastasis, and we completed hepatectomy 2.5 months later following 2 more cycles of chemotherapy. Our 30-day mortality is about 40%. This was the first Klaskin tumor case. We saw patient that because of bile leak and sepsis, and 90-day mortality was 8.3%. This second case was a HCC, and disease progressed very fast following the surgical procedure, and we experienced no mortality over the last 70 years. And here I want to show you some examples of how ALPS procedure looks like and how this is able to grow the future liver remnants. As you can see here, very small future liver remnant. Laparoscopic ALPS procedure was done, and from 520 milliliters to 670 milliliters. And 2 months later, the future liver remnant is 780 milliliters. Here again, this was a colorectal cancer liver metastasis. Preoperatively, we found there's a very small future liver remnant after the first stage, and 3 months later, the second stage. It exceeded 1 milliliter of liver. This is another one, a huge malignant tumor here right-sided, a small future liver remnant. Again, a laparoscopic ALPS. Here, the laparoscopic ALPS means the first stage was completed laparoscopically, and the second stage was an open procedure. Okay, it's grown up to 880 milliliters. And 6 months later, we have a very good vital liver parenchyma here. Etiboringiz, uçun rahmat.
Thank you. Good presentation. And do you have questions, please? Please. Give you a microphone.
Thank you, Professor, for a very nice presentation. I noticed that you perform ALPS for a future 3-segmentectomy. Is it a little too wide indication for ALPS? Because we see that the ALPS have a very high morbidity and mortality. Maybe on this way we will lose more patients from the ALPS than from the future liver remnant failure. So please, can you make a comment?
We performed this for future liver remnant combining, including 3 segments?
No,
What?
So that you make ALPS for the patients where you plan to make the future 3-segmentectomy.
Yes, 3-segmentectomy.
Less than a right hepatectomy.
No, it's not less than. It's 3-segmentectomy. Yeah, mostly extended hepatectomy.
Is it the indication? Okay.
Yeah.
Less from that, we will lose the more patients from the ALPS than from the liver remnant failure.
No, liver remnant failure is not something that we have significant experience after. Actually, the highest bilirubin level after this ALPS procedure performed for 24 patients was 3.8, then dropped down.
Thank you. So your indication was extended right hepatectomy. Future extended right hepatectomy was your indication for the ALPS, yeah?
No, future liver remnant was mostly extended right hepatectomy, preserving left sides.
Okay.
Yeah, but we also performed some reversal ALPS. So we resected segment 5, 8, 4, 2, and 3. So we preserved only segment 6 and 7. This is called reversed Alps. Thank you very much.
Thanks. Please, next question.
Thank you, Professor, for your good presentation. In your own experiences, you mentioned performing the second stage after 2.5 months later.
One case, only
One case. And did you encounter any additional difficulties when you practiced the second surgery? And during the first stage, do you prefer any measures to facilitate the second surgery? And when you do in your practice and you decide to make second stage after a bit time later, what did you do? What did you do? Or
okay, that case we had to perform the second stage 2.5 months later. So in between, patient received chemotherapy. Of course, there were some adhesions around. At that time, we actually performed classical Alps. So we totally, tape right hepatic artery. We tape short hepatic veins. We tape right hepatic vein. So we cut the liver all the way down at that time. So I believe it's really now I believe it's dangerous, not too much safe. We had some adhesions, but finally we were lucky and completed this second stage because we waited 2.5 months. If we tried to, perform the second stage, for example, 1 month later, that would be much more dangerous, I believe. But you asked, you have something, any tool to make it easier to perform the second stage. It's partial Alps. Don't touch too much. Just only portal vein, tape, ligate, transect the liver, that's all. Never touch anywhere else. For example, right hepatic vein, never mobilize the liver. These all are in the second stage.
As you know, some of surgeons doing something, taking the right liver in a bag or doing something to make second surgery easier.
I believe dangerous.
Okay.
Don't touch. Just ligate portal vein and transect. That's all.
Okay, thank you.
Liver shouldn't be mobilized. Right liver, no.
Thanks. The question is finished. Thank you. Next time we have social program.
Okay, we have now come to the end of this wonderful congress. I now invite their closing remarks, Professor Tashev and Professor Kerem.
Дорогие коллеги, у нас несколько сертификатов, которые доложили вчера и сегодня. Это наши из нашей республики, наши спикеры. Это в основном из Национального детского медицинского центра, сотрудники, которые это центр, который в последние годы очень быстро развивает и науку, и медицинскую обслуживание населения нашей республики на самом высоком уровне. Сейчас я вручаю сертификат Насиру Мансурджак. Так, Анвар Ходжаева, Шахзода. yaş istedatlı kırıklarım. Mama Nazar, İkbalca. Just brother, that's a bit. E'tiborlarınız uchun rahmat. Hozir siz Mustafa Kerimga beramiz. Kongressimiz prezidenti va tashkilotchisi.
Before closing speech, I also want to give the October Tashev certificate, and we have some surprise for him.
He did excellent job. And during these days, he invited us, he made this Congress. He is the teacher of us and who was dear us and who started this Congress, who worked, who did it, who ran it. He is the best of the best, our Professor October Tashev. Congratulations. Siz bo'lmasangiz bu kongress bo'lmas edi, domla. Hamma xizmatlaringiz uchun kattakon rahmat sizga. Trans-Caspian assotsiatsiyasi tomonidan sizga kattakon rahmat. Doim shunday doim sog' bo'lib, xursand bo'lib yuring. Oh, wait.
Oxirida yana shuni aytmoqchimanki, demak, mana bu kongressni Trans-Caspian Hepato Pankreato Biliary xirurglari assotsiatsiyasini ikkinchi kongressini Toshkentda o'tkazilishini ruxsat bergan va buni o'tkazilishi uchun Turkiyadan turib mana shu yerda tashkil etilishiga har tomonlama yordam bergan inson professor Mustafa Kerim bo'ladilar. Mustafa Kerimga tashakkur.
Okay. Dear colleagues, participants, ladies and gentlemen, we have successfully concluded the second International Trans-Caspian and joint meeting of the Balkan EHPB chapter of Congress. Our conference was attended by 53 faculty members from 14 countries and total nearly 400 participants plus online participants. The scientific content was well received by all attendees, and the social aspect of the conference was truly impressive. Welcome reception, presidential dinner, gala dinner were magnificent, and our exciting friendship were strengthened, and we made new friendships. From the moment we arrived in Taşkent, I have felt the warm hospitality extended to us. I like to express my sincere thanks to all faculty members who contributed to the organization of our conferences, to Trans-Caspian, Turkish, and Balkan HPB Association, and the Congress main sponsors, the Turkish Cooperation and Coordination Agency, TİKA. I am grateful to our colleagues from Azerbaijan, Bulgaria, Croatia, Germany, Georgia, Kyrgyzstan, Kazakhstan, Russia, United Kingdom, Turkey, Serbia, and Uzbekistan. I like to thank Professor Oktayber Tashayev and every member of his for their efforts in ensuring for successful organization of the Congress. I am very grateful for their warm hospitality, sincerity, and kindness. I want to ask for a big round of applause for them from all audience. Please stand up. And I want to all come here for the last picture. Thank you very much. Kattab Rahmat.